Welcome to our discussion for our anatomy of the eye. The anatomy of the eye is the first in the series of lectures that we're going to be able to give to you. The anatomy itself is very, very important and it's basically the foundation of everything. So, without further ado, let's start with why you need to understand what anatomy is. It's a very, very boring subject. We're just talking about parts of the eye. You don't even know what it's for. They're going to give you numbers, you're going to give you names that will usually be very, very boring until you know later on you understand how it all works because of how these parts are laid out, on how these nerves, the blood vessels are functioning. You'll now be able to understand why the patient had the problem, why the patient got infected, why the patient cannot see, or why the eye is no longer moving the way it's supposed to do. So it's basically understanding how it works and why its functions are being disrupted. The topics that we will be discussing will be the orbit, the eyeball, the extraocular muscles, where we will refer to it from here on as EOMs. Okay, so if you hear EOMs, it's extraocular muscles. Then we'll move into the ocular adnexa, meaning the parts around the eye, and the optic nerve, the biggest nerve in your body. So let's start with the orbit. So the orbit is very much like a pear. So when you see a pear, think of the orbit. Now it's very, very unique because look at the shape of the pear. That's how your eyes usually are shaped, and the optic nerve would function as the like the stem of the pear. So if you look closely with the shape of the fruit and the shape of the orbit, they look very much alike, with the stem of the fruit correlating to the optic nerve. So the orbit is basically a small area. It's practically about 1% of your entire body. It's basically about 30 cc or 30 ml in volume in adults, and the eyeball occupies just a small part, only about 20%. The rest of your orbit, that bony area, is filled with fat and muscles. The picture you're seeing here is the basic layout. You can see the muscles, and the area in between the muscles and the eyeball is usually filled with fat. Okay, so usually that's also one of the reasons why when you lose some of those fat, the eye seems to look sunken, and when you have an enlargement of those fat or the muscles, the eye seems to be popping out. You see those cases in thyroid patients with thyroid problems. Now, the anterior-most part of the orbit is called the orbital septum. The orbital septum is what separates the eyeball from, the orbit from everything else in front. Next, we move into the parts of the orbit. When you say the orbit, it's basically the space in the skull. Well, you probably saw this in a lot of movies. It's the area in the skull wherein you have that contains the eyeball and the muscles. So the the walls of the orbit is actually made up of several bones. It's not just one bone with a hole. These are several bones that are pieced together very, very well. And this area is actually like a jigsaw puzzle. So there are 7 bones: the maxilla, the frontal bone, the zygomatic bone, the ethmoid bone, the lacrimal bone, the sphenoid bone, and the palatine bone. In order to memorize this, we made a mnemonic: many friendly zebras enjoy lazy summer picnic. Okay, so right now it just sounds like we threw in a bunch of names, but these are very, very important because each of these bones are actually very important in the behavior of the eye. Again, if you notice, the one on top is the frontal bone, part of the skull. Um, there are several sinuses in that area. The sphenoid bone also has several sinuses, the maxilla sinuses, and the zygomatic bones, and the other areas are actually important. In particular, the area at the floor of the orbit is the weakest, the thinnest part. So if you have a trauma, somebody punched you, or you had a very, very strong trauma on the eye, usually that part, the floor part, is the one that breaks. So the roof of the orbit is created by the the orbital plate of the frontal bone. Then the lesser wing of the sphenoid bone, the medial portion is from the orbital plate of the ethmoid bone, the lacrimal bone, the frontal process of the maxilla, the lesser wing of the sphenoid bone. The floor would be made out of the orbital surface of the maxilla, the zygomatic bone, and the palatine bone. The lateral part will be made out of the zygomatic bone and the sphenoid bone. In order to memorize this, remember that each wall shares a bone with the next wall. Okay, so you can have the roof would have the roof and the lateral would have the sphenoid. The lateral and the floor would have the zygoma. The floor and the middle part would have the maxillary. The medial and the roof would have the sphenoid. Again, if you can learn how to draw this, it would be able you would be able to actually map this out. So in the boards or in any examination that you are asked to for parts of the orbit, you can just draw this. The sphenoid is in the roof and the lateral. The zygoma is in the lateral in the floor. The maxillary is in the floor and the medial. So you'd be able to map this out very, very fast. Now, the orbital apex, it's the part of the orbit that's at the very, very back part of the orbit. Remember, it's shaped like a pear. That is where the stem is coming from. It's a very important part because that is the entry area of all the nerves and blood vessels of the eye, and the origin of all the EOMs, with one exception. Okay, there's only one exception. This is the only EOM that doesn't originate from the orbital apex, the inferior oblique. So again, it's at the very back part. Then that is the part that we encircled. That is the orbital apex. The front part, the where the margins are, is basically like the fattest part of the pear, and the apex is the thinner part of the pear. Now there are two very, very important openings at the back of the eye: the optic canal and the superior orbital fissure. Okay, those are the two most important openings at the orbital apex. The superior orbital fissure, we will now start calling it as SOF, just to make it easier. It is actually located between the body and the lesser wing of the sphenoid bone. Now, why is the superior orbital fissure very important? it it actually works with the annulus of Zinn. So basically, it's a tendon, a mixture of tendons of four rectus muscles. Again, it's the origin of all four rectus muscles. You only have four rectus muscles in the eye, and you have two oblique muscles. So all four rectus muscles originate from the annulus of Zinn. Now, the annulus of Zinn and the superior orbital fissure are important because the annulus of Zinn is actually bisecting the superior orbital fissure. It's in the middle. Now, if you notice, your body doesn't really create structures out of the blue. It's very, very important, and the superior orbital fissure is the biggest opening in the back of the eye, or the orbital apex. Now, the annulus of Zinn is bisecting this, and in so doing, it actually created separations. Okay, so you notice that the annulus of Zinn is in the middle, and then some nerves and blood vessels are coming out. Now, it's important for you to understand which blood vessels came out and which blood vessels are outside of the annulus. So outside of the annulus, you have the superior orbital ophthalmic vein, you have the lacrimal nerve, you have the frontal nerve, and you have the trochlear nerve. Now, why do we need to remember this? Because one of the best way to anesthetize the eye is called a retrobulbar anesthesia. That means we inject the anesthesia into the back part of the eye, but not just in any other part of the eye. It's at inside the muscle cone. So the muscle cone actually contains the anesthesia, and so everything inside that muscle cone gets anesthetized. Now these nerves, the lacrimal, the frontal, and the trochlear nerves, did not go into the muscle cone. So that means you will not be able to anesthetize these three nerves. So these are the ones that came out of the annulus of Zinn. So this is how it looks. So the nerves actually came out from the outside of the muscle cone. So they will be able to escape the anesthesia that is delivered inside the muscle cone. Now, those that came out of the annulus are the oculomotor nerve, the superior and inferior division, the abducens nerve, and the nasociliary nerve. So, these parts, these nerves could actually be blocked by just injecting the anesthesia inside the muscle cone. The tip of the muscle cone is the annulus of Zinn, and these are the more important ones. Now, these nerves are important because these are the nerves that actually control your muscles. So if I inject an anesthesia inside the the muscle cone, right at the back of the eye, I would have paralyzed all four of the rectus muscles, and probably and well, even the sensory nerves. So the eye would now be anesthetized and will not keep on moving, making it easier for us to do surgeries. Now, there's a vein that doesn't really conform with the rule. It can pass anywhere. It can pass inside the annulus of Zinn. It could be at the top, or sometimes even at the bottom part after the annulus of Zinn. So this is a quirk in the anatomy. The inferior ophthalmic vein doesn't really follow any rule, so you can find it sometimes inside the annulus of Zinn and sometimes on top or below. Okay, so the nerves passing through the superior orbital fissure are the lacrimal nerve, frontal nerve, the trochlear nerve, the superior division of the oculomotor nerve, the abducens nerve, the nasociliary nerve, and the inferior division of the oculomotor nerve. You can use this memory aid to remember those nerves. So leave frankly to see absolutely no insult. Okay, you can just review this later on. Moving on. So those that pass through the optic canal, which is also within the annulus of Zinn, is the optic nerve and the ophthalmic artery. Now, these are two of the most important nerves and blood vessel, in particular the artery, that will pass through that area. So, this is that area. This is where the optic nerve and the ophthalmic artery will pass through. Now, the optic nerve is the biggest nerve practically in the body. It's the nerve that controls everything that you see. So everything that you see, everything that the retina sees, gets passed through the optic nerve. So if you cut this nerve, your patient will go totally blind, as in totally blind. And this nerve does not regenerate because it's practically part of your central nervous system. So it's not one of those peripheral nerves that may theoretically regenerate, but as part of the CNS, this does not regenerate. And the blood supply of that area is the ophthalmic artery. So basically a branch of the internal carotid artery. So the blood supply of the area is the central retinal artery supplying the retina. You have the lacrimal artery, supplying your lacrimal gland and your upper eyelid. So basically, your tear glands. Then you have the muscle branches going to each and every one of the extraocular muscles. It becomes the anterior ciliary arteries later on, which supplies the episcleral, sclera, and limbus, and even the conjunctiva, and later on becomes a contributor of the major arterial circle of the iris. We'll show you later on why the major arterial circle of the iris is a very, very important structure. The long posterior ciliary arteries supply the ciliary body. The ciliary body basically is responsible for producing your in particular the ciliary processes in producing your aqueous, which is basically the lifeblood of everything that's inside your eye. It combines with the anterior ciliary arteries to form the major arterial circle of the iris. Again, you hear that, major arterial circle of the iris. So it's basically like a rotunda, an area where everybody meets. It's basically like a melting pot. And you have the short posterior ciliary arteries supplying the choroid and part of the optic nerve, and the medial palpebral arteries supplying both eyelids. Again, if you notice, very, very important, almost all the major parts of your eye and the parts around the eye are supplied by blood vessels that are coming from the orbital apex. The venous drainage starts from the vortex veins and going into the anterior ciliary veins, the central retinal veins, and is now going to the superior and the inferior ophthalmic veins. Okay, so I need to remind you that the ophthalmic veins are connected to the cavernous sinus. The skin of the periorbital region, the areas around the orbit, in particular your eyelids and the small area around the eyelids, drain through the angular veins and into the branches again of the superior ophthalmic vein. Again, we need to remind you, ophthalmic veins are connected to the cavernous sinus. Why is that important? Because of the phenomenon called cavernous sinus thrombosis. Now, cavernous sinus thrombosis is a very dangerous phenomenon because it's basically a waypoint. It's an area where when you reach it, it could go to any parts of the body. So, if the ophthalmic veins are connected to the cavernous sinus, any infection from that area, the skin around your eye, on your eye itself, any infection, any abscess from that area could find its way into the cavernous sinus. And if you notice the system, it could spread from that area to practically the entire brain. So it could a very, very small infection in front of your in a very small area of your skin could find its way into the brain. So it's that dangerous. So again, a bigger look. The cavernous sinus is the one in the middle, and spreading to all the parts could easily be done by just getting the abscess or an infection, or even let's say a small cancer cell in that area could spread easily to the entire brain. So a simple injury could later become an encephalitis or probably become a very, very bad stroke. Next, we move to the eyeball. Now, the eyeball is where everything actually happens. The first part of your eyeball, the major part, the white part that you see is called the conjunctiva. It's very thin, it's transparent, and it's basically a mucous membrane. So it's not just skin, it's actually moist. It only covers the globe in front. Okay, so the conjunctiva doesn't extend to the back of the eye. It's just in front. You have two parts of the conjunctiva, the part that is covering the eyeball and the part that's covering the eyelids. but only the inner part of the eyelids are covered. Now the bulbar conjunctiva ends at the limbus. That's where the black part and the white part of your eye meets. So in this case, that's the number 1 in the label. You can just zoom in later on. And these two parts of the conjunctiva are actually connected at the area we call the fornix. So the fornix is where your palpebral and your bulbar conjunctiva meets. So where is the fornix? The fornix, you have one below and you have one above. That is the conjunctiva on your upper eyelid meets the conjunctiva on your eyeball. The conjunctiva on your lower eyelid also connects to the conjunctiva of your eyeball. Now, in this case, that is labeled as number 3. You can just expand this later on and zoom in and see that part. But that area is what we call the fornix. Now, your conjunctiva, you have layers of your conjunctiva. It's not a simple skin. You have the epithelium, which is about 2 to 5 layers of stratified columnar epithelial cells. You have the superficial epithelial layer, which is mucus secreting because it has goblet cells. And the basal epithelial layer, which may contain pigments, especially near the limbus. So sometimes you see the patients with small brown markings at the limbal area. Those are basically just the basal epithelial layer with melanin pigments. Now, the epithelium is not a dry skin. It's mucus. It's mucus filled because it has goblet cells. The stroma is basically an adenoid superficial layer and a fibrous deeper layer. Now, the adenoid superficial layer has lymphoid tissue and follicle-like structures without germinal layers, and the fibrous deep layer will have connective tissue basically attaching itself to the tarsus, and it's loosely arranged over the eye. Now, that means the conjunctiva on your eyelid is attached very, very well to the eyelid. The tarsus is basically a very, very thick fibrous tissue. So it's very hard to pull the conjunctiva away from the eyelid, but it is easily pulled away from your eyeball. Okay, that's a difference because the conjunctiva over the eyeball moves, and the conjunctiva over the eyelids are very, very stiff. It also contains the glands of Cross and Wolfring. The glands of Cross and Wolfring are similar to the lacrimal glands, both in form and function. Okay, so they're basically like modified lacrimal glands. The Wolfring would be at the orbital border of the tarsal plate, meaning it's at very, very well at the fornix area, and uh, the glands of Cross would be in the stroma of the conjunctiva. This is how many glands you have on your eye surface, and this is just on the eyelids. You have glands even in your eyeball, but okay, so the glands of Cross and Wolfring would be the ones on top, glands of Cross and Wolfring. Now, the conjunctival arteries basically is a mixture of the anterior ciliary artery and the palpebral arteries joining to become conjunctival arteries. So it's very hard to remove perfusion in your conjunctiva because two separate arteries are actually supplying it, both the palpebral arteries and the anterior ciliary arteries. It's innervated by the ophthalmic division of the first, it's the first division of the trigeminal nerve, and brings us to the next layer, the Tenon's capsule. The Tenon's capsule is a fibrous membrane. It covers the eye from the limbus to the optic nerve. So the difference between Tenon's capsule and the conjunctiva is Tenon's capsule is covering the entire the eyeball, and the conjunctiva is just covering the front part of the eyeball. Okay, so the Tenon's capsule is actually fused with the episclera in the limbus, and it's also fused with the fascia of the muscles. So since it's covering the entire eyeball, everything that interrupts that that smooth layer becomes fused with it. So the limbus is where the eyeball is fused with the cornea. So it fuses with the episclera at that area, and with the muscles, since the muscles are actually connected to the eyeball, the Tinon's capsule would then be fusing with the fascias of the eyeballs. It becomes what we call check ligaments, okay, as in check, and it's fusing with the fascia of the inferior rectus and the inferior oblique muscles, and forms the suspensory ligament of Lockwood, which becomes later on a very important um, ligament, because this is the ligament that controls your one of your oblique muscles. The next layer would be your sclera and episclera, basically the white part of your eye. The sclera is a fibrous outer layer of the eye, basically consisting of collagen. It's very, very thick. It's like dealing with the white part of the egg. If you look at it, you don't see any structures inside. It's just one big, thick layer of collagen. It's dense. It's white. So if you see any other color at the sclera, it's not the sclera, you're seeing something else, or it's pathologic. So if your sclera becomes very thin, you start to see the layer behind it, which is the choroid, and the choroid is pigmented. So if you see a sclera and it's not white, you're seeing it as blue or brown, then you're actually seeing the choroid. Okay, if you're seeing a different color of the sclera, then it's pathologic. It's continuous with the cornea and the optic nerve, the covering of the optic nerve, which is basically the dural sheath. The thinnest part of the sclera is insertion in the intraocular muscles, which is basically about zero point 0.3 millimeters. And the rest of the sclera is actually double that size. So it's thinnest at that area. Now, why is this significant? That means if you get punched in the eye, this is the area where your sclera might break. Okay, this is the area where your sclera is thinnest, and it's a weakness in the sclera. So any trauma in your patient would usually trigger the that problem. Now the episclera is the layer on top of the sclera. It's very thin and it's elastic. It contains blood vessels that nourish the sclera. Okay, we call it episclera. It's on top of the sclera. That's why the name is. That's why they named it, well, episclera. Now, episclera is important because this could be separated from the sclera, and sometimes it's useful to either put medications in this area because it traps the medication. It's also useful for glaucoma surgery because this is where we can divert some of the aqueous in the episcleral area. Since it has blood vessels, it will um, be able to return the aqueous that was diverted into your circulation. Okay, so we'll be discussing more of that later on during our glaucoma topics. So this is a patient with episcleritis. Now, usually the episcleral vessels are very, very fine. In this case, if you notice these blood vessels, they're very, very fine, they're very, very small. And these blood vessels are actually very, very prominent. That's why it's called episcleritis. Now, if you look closely at the blood vessels, they're not going in just one direction. It's like one bunch of blood vessels piled up on top of the other blood vessels. They're all going separate directions, and they're like multi-layered. The reason for this is the conjunctiva is congested, your episclera is congested, so you have blood vessels on top of blood vessels, and since the conjunctiva is on top and the episclera is at the bottom, you can see several layers of blood vessels on top of each other. So this is not just a conjunctivitis, which is basically just an inflammation of your conjunctiva. This is also an episcleritis, which is a congestion of your or inflammation of your episclera. Next is actually one of the more important parts of your eye, the cornea. It has several roles. It's protective and it's refractive. Protective because it serves as a defense of your eye. The cornea, the behavior of the cornea is actually one of the more perplexing, more confusing behavior of the eye. The protective nature of the cornea means that your eye drop doesn't really just get into the eye. That's why a lot of the scientists are basically experimenting on which type of fluid will be able to penetrate the eye if it's dropped, because the cornea is both hydrophilic and protective at the same time. It's waterproof, at the same time it keeps things from getting through. It's also refractive because it is the most powerful lens in your body. Okay, so your body has several lenses that diverts everything that you see into the retina. It has two major ones: the cornea and the lens. The cornea is the most powerful. That is why when we do a LASIK surgery, that is the area that we try to modify the cornea, because during LASIK surgeries, it's the cornea. Um, Modifying the cornea makes the most or the best result when you try to decrease the grades of your eye. Now, your cornea is basically transparent. We can see inside the eye, and because the cornea is transparent, you can see the blood vessels at the retinal area by just looking through the cornea. That is the only way for you to be able to see blood vessels actually working inside your body. When you look at your arms, you can see blood vessels, but they're covered with skin. You know they're blood vessels because the colors are different. In If you look through the cornea, because it's transparent, you can see all the blood vessels inside. You can see RBCs actually going through the capillaries. The cornea is inserted to the sclera in an area we call the limbus. It's where the white part and the black part of your eye are meeting. It's thicker at the edge, about 0.65 millimeters, and it's thinnest at the center. So at the very edge, it's very, very thick, and the center, the area where you actually use to see people or to see everything else, it's at the thinnest area. Now, LASIK usually treats only the central 4 millimeters of the center of your cornea. Now, a cornea would have a normal diameter of about 11.75 millimeters and 10.6 millimeters vertically. So it's not perfectly round. It's like ovoid. It's like an oval. It's like a football. It's a little on the oblong side. Now later on in the discussion in the lecture on cornea, you'll be discussing how small changes in this diameter will actually make your patient pathologic. Okay, so you will probably be able to make critical diagnosis just by measuring the cornea. Now your cornea has several layers. So the epithelium is the outermost part. It's the one in the air. It's the one in the tears. It has 5 to 6 layers of cells. The Bowman's membrane is acellular. It's a very, very thin membrane at the back of the epithelium. The stroma is most of the thickness of your eye. And it's optically clear. It's crucial because the way the stroma was arranged and the stroma behaves determines if your eye or if your cornea is clear. The Descemet's layer is the basal lamina of the endothelium, and the endothelium is the single cell layer with a detergent function, meaning the endothelium is the cell pump of your cornea. If fluid finds its way inside the cornea, the endothelium's work is to pump it out back into the aqueous. So it keeps the cornea dry. It keeps the cornea from being flooded by fluids. If that single cell layer of endothelium gets damaged, then your cornea becomes opacified because fluid cannot be pumped out anymore. So the same way with floods, if you cannot pump out the floods, the water will stay there. But if you have a very good functioning pump, even if the flood is very high, you could eventually be able to remove the water in floods. Now, your cornea behaves very differently from the rest of your body. For example, your epithelium um, repairs itself very, very fast. So think of superheroes, Wolverine, wherein if you get damage within 24 hours, the epithelium would have repaired itself. It moves that fast. So a slice, a damage, a laceration in your epithelium gets healed over within 24 hours. It moves very, very fast. Now, the stroma is where LASIK works. When we do LASIK surgeries, we try to decrease the grades of your eye. We try to decrease the stroma. The endothelium and the epithelium doesn't play a role, except that if epithelium heals slowly, then your patient will be in pain for longer time. And by the time you hit the endothelium, you've actually cut open the eye. So try not to do that. Now, there's a new discovery only about 10 years ago. It's called the dual layer. It's crucial usually only for surgeries. It's a thin layer of collagen between the corneal stroma and the Descemet's membrane. We'll show you that later. It's crucial for three new surgical techniques: the PDEC, the pre-Descemet's endothelial keratoplasty, the dark triple, basically dark with phacoemulsification with an IOL implantation, and compression suturing of the Duas layer in acute hydrops. Now, what does this all mean? It means if you put fluids in between if you put fluids in the cornea and your dual layer is broken, then you will have a hard time controlling it. You will actually have problems with leakage and edema. But if your dual layer is intact, it will hold the fluid in that area and the fluid will not be able to leak out. So the dual layer, okay, so let's remove my picture here. The dual layer would be at the very back of the eye, in between the Descemet's layer and the stroma. So again, it's waterproof. They call it airproof. They call it waterproof. So basically, if it's broken, then fluid seeps in. It's not it doesn't really work that well. The reason why we're not including it into the 5 layers yet is because a lot of scientists are actually questioning whether it really exists or it's basically just a quirk in some of the patients. Okay, the nutrition of the cornea comes from the vessels of the limbus, the aqueous humor, and the tears. If you look closely, there are no blood vessels in your cornea. So it will get its nutrition from somewhere else. Those near the limbus will get the fluids from the vessels at the limbus. Your limbus is full of small blood vessels, so your cornea gets nutrition from that. The aqueous humor from behind the cornea would also be providing the nutrition and the oxygen that's needed. And the front part of the eye would be reliant on tears. Now, this is important because if you disrupt your patient's tears by having a problem with their tear glands, or you disrupt the flow of the tears by covering that area with, let's say, a contact lens that um, is sticking to the cornea, then you would disrupt the nutrition of the cornea and your cornea could die off. Your cornea is innervated by the ophthalmic division of the trigeminal nerve. So if you cut this ophthalmic division, then your cornea would be basically be numbed. Your cornea is actually one of the more sensitive parts of your body. It will register pain from a single strand of hair that hits it. And your transparency of the cornea is not a permanent thing. It takes work. Um, it takes a lot of work and organization from your cornea to keep it transparent. That means your cornea could lose its transparency later on. It could become opaque. One is its uniform structure. The stroma is actually layered very, very uniformly. It's layered very, very well. It's avascular. That means there are no blood vessels. I told you again where the nutrition is coming from. If it doesn't have blood vessels, and detergents, meaning it's dry. And this is a picture. The light bar is a picture of your endothelium. So this is a called a scleral microscopy. Um, the the endothelium is responsible for keeping your cornea dry. It's pumping the fluids, excess fluids out of the cornea and into the aqueous. So if you destroy this, if you damage this area by too much heat, by surgery, by trauma, then that area without an intact endothelium would suddenly become opaque, and water and fluids would start flooding your cornea. Next would be the uveal tract. Now, the uveal tract is actually a composition of several um, the uveal tract is several structures inside the body. The iris, that's the color of your eye, the ciliary body, and the choroid. So it's not just one part. It's the colored part of your eye, it's the big ciliary body behind the iris, and the choroid that's surrounding the the eyeball. It's basically just beneath the sclera. Now, it's the middle vascular layer of the eye, and it contributes to the blood supply of the retina. Okay, so again, what's the upper vascular layer of the eye? It's your conjunctiva, your episclera. What's the lower or the innermost vascular layer of the eye? It's the blood vessels in your retina. Okay, but the retina is not just supplied by its own blood vessels. The uvea supplies the innermost part of the the outermost part of the retina. Okay, so let's attack each piece. The iris, it's the central, the one with the central opening we call a pupil. It's a flat surface, and it divides the eye into the anterior and the posterior chamber. So when we say the anterior chamber, we're talking about the iris and everything in front. So that means the back of the cornea to the iris. And the posterior chamber is described as the iris and everything behind it going towards the retina. Sometimes they just say it's up to the just to the lens, and they call the retina posterior pole. So it depends on what the speaker is actually intending to say. So layers of the iris, there are only two: the stroma and the pigmented epithelial cells. Now, the stroma is the pigmented fibrovascular layer, and you have two stroma inside: the sphincter pupillae and the dilator pupillae. And you have the pigmented epithelial cells. The blood supply of the iris is very, very complicated. This is what we were kept telling you about. The major circle of the iris, that's the one on top. Those are the blood vessels from the iris. And iris capillaries are non-fenestrated, meaning they do not leak or they're not supposed to leak. Okay, so unlike the capillaries inside your kidneys, which are fenestrated, these are non-fenestrated and they're not supposed to leak. If you notice, the major circle of the iris is supplied by blood vessels coming from all over. So it's basically like a roundabout or a rotonda, wherein you have a circle or a circular road and leading out to different areas, to different other roads. So blood vessels of the iris are are being supplied by blood vessels from different parts. It's supplied by the ciliary nerves, and your eye color, whether your eyes are brown, blue, green, gray, or hazel, is determined by the melanin in the iris pigment. Now, the melanin is in the iris stroma. It's not in the epithelium, and it's determined by the cellular density of the stroma, how how thickly packed they are, and how much melanin it has. Now, there is no such thing as a blue, green, or hazel pigments inside the eye. When you see somebody with blue, green, or hazel eyes, so basically there are just tyndall scattering of the light. Very similar to when lights are bent when it's filtering through the trees, or when there's smoke. So it's you need light angled at a certain direction for you to be able to see blue, green, or hazel in somebody's eyes. Again, there are no blue or green pigments inside the eye. So even if you're talking to a blue-eyed person, it's just the number of melanin inside the eye. Okay, there has been a theory before that a blue-eyed person is it's recessive. It has already been disproven. Okay, and the pupil basically is controlled by the balance between the parasympathetic and the sympathetic activities in the eye. So the parasympathetic activity is basically constriction of constriction of the pupil, and the dilation is from the sympathetic activity by the sympathetic nerves. Now the parasympathetic activity is controlled by a third cranial nerve. So if you cut the third cranial nerve, your patient would practically be dilated. Or if you actually just interfere with the cranial nerve, third cranial nerve, your patient would have a blown out pupil. Okay, next would be the ciliary body. It's the muscle, it's the area behind the pupil. It has two zones, the pars plicata, which is about 2 millimeters wide and contains the ciliary process, and the pars plana, meaning it's the flattened area. Okay, so pars plana, flat, plicata means you have ciliary processes. The ciliary processes is composed of fenestrated capillaries and veins and produce the aqueous humor. Now you notice the capillaries are fenestrated, meaning it leaks. And that is the reason why it produces aqueous humor. The aqueous humor is not just blood, it's not just water, it's basically fluid with the proteins and the RBCs filtered out of it. So it's very nutritious, it's filled with oxygen and functions as the blood supply of the lens and the cornea. So again, two very, very important parts of your body. The ciliary muscle, there are actually three: the longitudinal, circular, and the radial muscles. The longitudinal opens the trabecular meshwork. So when these muscles contract, the trabecular meshwork opens up, or the meshwork widens. The circular muscle changes the shape of the lens. Therefore, it controls your accommodation. So when you're looking at something that's very near, your ciliary muscle actually relaxes. And when you're looking at something very far, sorry, the other way around, looking at something that's very near, your ciliary muscle contracts, and when it's looking at something that's far away, it relaxes. So that's why when we paralyze the ciliary muscle during cycloplegic refraction, we actually prevents the patient from accommodating. Okay, so the patient will be able to, they will not be able to change the shape of their lens, so that we may be able to determine the actual grade of the patient's eye. Okay, the radial muscles, we're not really sure what it does. It's theorized to help the longitudinal muscles in opening the trabecular meshwork. But again, as we said, we're not really sure what it's doing. The ciliary blood body also has supply of the blood in the major circle of the iris, and the ciliary nerves are actually um, supplying the nerves of the ciliary. It controls the ciliary body. Now, the next part would be the choroid, which it's the one that's feeding the outer portion of the retina. It's the posterior portion of the uveal tract. Um, the front part is the iris and the ciliary body. The internal portion of the choroidal vessels are called choriocapillaris. That's the area nearest the retina, and it's drained by one vortex vein per quadrant. So you'll actually have four of those. So you have four vortex veins, one per quadrant. Moving in, we're looking at the lens. The lens is basically named crystalline lens. It's biconvex, it's avascular, and it's very, very clear. It's about 9 millimeters in diameter by 4 millimeters thick. It thickens more the older you grow, because it more lens fibers are produced. It accumulates inside, and it's smaller when you're younger, and it's larger when you're older. It's the second most powerful lens in the eye. The first is actually the cornea. It's suspended by zonules, and the anterior part is the iris, and behind it, it's the vitreous. Now, the lens is covered by the lens capsule, which is semi-permeable. That means some fluids can get in, but not all. Single-layered anterior or subcapsular epithelium. Again, this is the only area in the lens with a nucleus. One layer of epithelium. And the rest of the lens is filled with a non-mitotic lens fibers. That means the anterior epithelium dies off at migrates at the sides, and when it reaches the sides, it elongates and it starts to lose its nucleus. So in theory, a cell without a nucleus is not a cell that's alive, because it doesn't reproduce. It's uniformly layered on top of the older fibers, and in such that the outer layer contains the oldest fibers, and the center is the oldest, and the outer is the youngest. We call the outermost the cortex, and the innermost the nucleus. Okay, so moving on. Your lens consists of about 65% water and 35% protein and minerals. Again, no blood vessels, no nerves, because it needs to be crystal clear. And it's mostly water. Well, because of the cellular structures. The innermost part of the eye is the retina. It's thin, it's transparent, it's multi-layered neural tissues, and it lines the inner wall of the posterior two-thirds of the eye. Again, not the entire back of the eye, just the posterior two-thirds. Because the front one-third is where your iris is where your ciliary body is, it's where your cornea is. Okay, so the front one-third of the eye doesn't have any retina. It extends all the way up to the ora serrata, which is basically just behind the ciliary body, and it's attached most to the ora serrata and to the optic disc. That means even if you have a very, very large retinal detachment, the last part that detaches is the part that is connected to the optic disc and connected to the ora serrata, being the outermost part. At the ora serrata, it is about 0.1 millimeter thick. At the posterior pole, meaning at the back of the eye, it's about 0.56 millimeters thick. That means it's thickest at the posterior pole. Now, the center of the retina is called the macula. It's what you usually look for when you're doing a fundoscopy in your patient. So the center of the macula, of the retina, is the macula. The center of the macula is called the fovea. It's basically a small depression inside the macula. And at the center of the fovea is the foveola. Okay, again, macula, fovea, foveola. So the very, very center is the foveola. The foveola is the area of the eye where it is pure 100% cones. It is the most sensitive part of your retina in terms of vision. So going up the 10 layers of the retina, the next part, the yellow ones are the nucleus of the cells are found. Okay, so the ganglion cells are the cells that bring the impulses. Basically, these are the runners. These are your FedEx. Um, these are the runners. They bring the impulses from the retina going all the way to your optic nerve and all the way up to into the brain. So that's called the ganglion cell layer. So the nucleus is in number 3. The legs are in number 2. Okay, the number 3, the inner nuclear layers are where the amacrine, bipolars, and horizontal cells, basically supportive cells, nutrition cells, support for the retina. And the last part is where the photoreceptors are. These are the film of your camera. This is the actual area wherein the light is actually detected, and then it's thrown up into the ganglion cell layer and then rushed into the brain. The white parts are basically connectors. Um, the nerve fiber layer of the ganglion nerve fiber layers, or the RNFL, are connecting the ganglion cell going to the optic nerve. The layer number 4, the inner plexiform layer, basically connects your ganglion with the inner nuclear layer, and the outer plexiform layer connects your inner layer with your outer nuclear layers. Okay, so photoreceptors going into the cells in the amacrine, bipolar, horizontal cells, which are basically connector supportives, and going into the ganglion cell layers. So 3 areas, very, very important with cells. You have, and in between them are connectors, and the greens are basically the membranes or the protectors of those areas. So this is how it looks. If you have a visual memory, then probably just look into this picture, memorize them. If you notice the layer number 7, the outer nuclear layer, is continuous all the way to the photoreceptor layer, layer number 9. So layer number 7 and layer number is continuous all the way to layer number 9. It's one cell. And the inner nuclear layers are connected all the way from 6 to 4. They're connecting the photoreceptors and the ganglion cell layers. They're the middlemen. It's basically, there are a lot of mnemonics for this. Most of them are confusing, most of them are, but find one that you really like, but you need to be able to memorize all the 10 layers of the retina by brute force or by using a mnemonic, but it usually will come out in any major exam. Now, your retina is supplied by the choriocapillaris, which is the outer one-third. Remember, the retina is actually facing inwards. So the outer one-third layer is where the photoreceptors are. The inner layer is where the ganglion cell layers are, where the nerves are. And the central retinal artery supplies the inner two-thirds of the retina. The fovea is supplied entirely by choriocapillaris because the retinal blood supply does not reach the fovea. It's only up to the area um, at the macular, very fringe of the macular area. So the fovea is supplied entirely by choriocapillaris, especially the center of the fovea. Remember, the foveola. Okay, retinal blood supply is non-fenestrated. They're not supposed to leak, and it's the reason why it's called the inner blood retinal barrier. So they measure this because some medications, if you take it orally or is injected into your blood, doesn't really go into the eye if it does not get through the inner blood retinal barrier. Now, choroidal blood vessels are fenestrated, meaning it leaks. The choroidal blood vessels are basically the outer blood retinal barrier at the level of the retinal pigment epithelium. Choroidal vessels are meant to leak, retinal blood vessels are not. Now we go to the extraocular muscles. For brevity, we call it EOMs, extraocular muscles. There are actually 6 of these muscles, 4 straight muscles, 2 oblique muscles, and all the 4 rectus muscles or the straight muscles originate at the annulus of Zinn. The superior oblique is the thinnest and the longest of the extraocular muscles, and the inferior oblique is the only one that did not come from the orbital apex. It originates from the nasal orbital wall. They all have different origins. It's the all the rectus. If you're asked for the origin, the answer is only one, annulus of Zinn. It doesn't matter medial, lateral, superior, inferior. If it's a rectus, it's coming from the annulus of Zinn. If it's a superior oblique, it's also coming from the orbital apex, but that's not the functional origin. The functional origin is the trochlea because the superior oblique bends. And when it bends, it's actually at the trochlea where it's pulling the eye. So it has a anatomical origin, the orbital apex, and it has a functional origin, which is the trochlea. The inferior oblique, it comes from behind the lacrimal fossa. Again, it's not coming from the orbital apex, it's coming from the just behind the lacrimal fossa. They have different areas of action. Now, only the medial and the lateral, the ones at the side, cause one action, adduction or abduction. Abduction is pulling towards, adduction is pushing away. So, medial rectus adducts, lateral rectus abducts. Opposite side. Lateral rectus pulls the eye away towards outside, and the adduction pulls towards the medial portion. Okay, so if you notice, superior and inferior rectus, they don't just function just one area, adduction, or elevation and depression. They function also in torsion and adduction because of the way your orbit is made. Your orbit is actually created like a pear, but it's tilted towards one side. So it's because of that, the superior rectus doesn't just pull it up, it pulls it not up but also towards towards the center, towards your nose. And the inferior rectus pulls the eye not just up but also towards the nose because they're oriented differently. The obliques are oriented on the opposite side. That's why they abduct, meaning they're pointing towards the ear. Okay, so again, just to make it easier for you to remember, adduction means pulling it towards the nose. Abduction means pulling it towards the ears. So also notice that the only one that creates intorsion and extorsion are the superior and the inferior rectus. The superior rectus intorts, the inferior rectus extorts. Okay? The superior oblique is opposite the superior rectus. So the superior rectus intorts. So innervation, all of the blood vessels are innervated by your or the EOMs are innervated by the third nerve, cranial nerve 3, except for two, lateral rectus and the superior oblique. So the way to remember this is just remember SO4 and LR6. Okay, superior oblique is the fourth, lateral rectus is the sixth. Everything else, if you're asked, it's the third nerve. LR4, LR6, SO4. Now, the spiral of Tilloch's is how your muscles are actually inserted into the eyeball. Spiral because it's nearest to the limbus at the middle rectus and it's farthest from the limbus at the superior rectus. So it's like a spiral. The middle rectus is nearest. Next would be the inferior rectus. The lateral rectus would be next. And the farthest away would be the superior rectus. Now, it's important when you're trying to locate where the muscles are during surgery or if you're trying to immobilize the muscles. Okay, so spiral of Tilloch's describes how the muscles are inserted towards in the eyeball. So the blood supply of the EOMs is the muscular branch of the ophthalmic artery. Except for the lateral rectus and the inferior oblique, they have additional inner blood supply from the lacrimal artery, from the lateral rectus, and the infraorbital artery from the inferior oblique. The ocular adnexa is the one that's around the eye, not just the eye, but around the eye, in particular your eyelids. Your eyelids, you have an upper and lower palpebra. They're basically folds of skin that protects the eye. And it's the blink reflex of your eyelid that helps spread the tears. The way that your tears are coming from the lateral rectus, the lacrimal gland at the upper portion, it goes all the way towards the lower part, towards the nasal area. And the reason that your tears are spread so well is because your eyelids, when your eyelids are blinking, it's pushing the tears very very thinly all the way towards the the punctums. Now, if you stop blinking, your tears are actually just going from one area to the other without any help, and your eyes starts to dry up. Now, when you say dry eyes, it doesn't mean the entire eye is dry. Portions of it could be dry, portions of it could be very, very wet. And the reason it spreads very well is because of your eyelids blinking. You have several layers. You have the skin. The muscles are under the skin. The orbicularis oculi closes the eyelids. And then you have fat tissue behind it. And you have tarsal plates. The tarsal plate is the main support of your eyelids. That's why your eyelids are not floppy, because the tarsal plates are gives it its basic structure. And you have your palpebral conjunctiva, which is attached to the tarsal plate. It's very, very hard to pull it away from the tarsal plate, unlike the conjunctiva that's on your eyeball. The lid margin is about 25 to 30 millimeters long. It's about 2 millimeters wide. That means it's not a single line. And it's divided by a gray line called the mucocutaneous junction. The front part, you have the eyelashes, you have the glands of Zeiss, which open to the base of the lashes, and you have the modified sebaceous glands, which is a modified sebaceous gland, and the glands of Moll are in a row at the base of the eyelashes, and it's those are modified sweat glands. Again, glands of Moll and glands of Zeiss. Glands of Zeiss is nearer to the tip, and the glands of Moll are at the base of the eyelashes themselves. The posterior margin of the eyelids is the one in close contact with the eyeball. Now, there are small orifices of the meibomian glands in that area that basically lubricates the eye. Now, the lacrimal punctum is the main drainage of your tears. If the punctums are not there or they're blocked, your tears will flow all over your face. But because of the punctum, it's basically your drainage. That's why even if your eyes are wet, it doesn't flow all over your face. It drains into the punctum and into your drains inside of your nose. You have two puncta per eye. You have the upper and the lower punctum. Now let's talk about the retractors. The retractors are the ones that open and close the eye. So the retractors are responsible for opening the eyelids. They're striated and smooth muscle components. The upper lid would have the levator palpebrae superioris, the Mueller's muscle, or the superior tarsal muscles. And the lower lid would have inferior rectus and the inferior tarsal muscles. Okay, lacrimal complex. This is basically where your tears are produced and drained. So it's produced on the all the way here in the superior lacrimal gland. You also have another gland in the in the orbit and in the eyelids. It drains into the outermost portion of your eye. It's on the uppermost outermost part of your eye. It drains towards the punctum, which is this area, and going through the lacrimal duct, lacrimal sac, and drains outside of the nose. That's the reason why when you cry, when your eyes are producing too much water, even your nose is crying. Okay, so it's composed of your lacrimal gland. You have the orbital and palpebral portion. You have parts in the orbit and parts in your eyelids. It's not just in your eyelids. There are some parts inside. You have the accessory lacrimal glands, which we mentioned before, glands of Cross and Wolfring. There's canaliculi, which is drained from the punctum. It goes into the canaliculi, it goes into the lacrimal sac, and into the nasolacrimal ducts. Again, just to remind you, glands of Cross and glands of Wolfring. And the lacrimal glands, they're all located in the uppermost portion. And this is how it drains from the lacrimal gland, from the punctum to the caruncle and into the nasolacrimal duct. An area here would be dilated. We call it the lacrimal sac. Here dilated, we call it the lacrimal sac, and it drains into the nose. So this part actually drains into the nose. Your lacrimal gland is nourished by your lacrimal artery. It's drained by your ophthalmic vein, and its lymphatics are in the preauricular lymph node. So any infection in your lacrimal glands, you will have small nodes in front of your ear. So you'll have lymphadenopathies in this area. The nerve supply of the lacrimal gland is your lacrimal nerve, which is sensory. It's just a branch of the fifth cranial nerve. You have the secretory innervation from the great superficial petrosal nerve, and you have sympathetic nerves. So if you disrupt any of these, it basically decreases the production of tears inside for your eyes. Now the last part would be the optic nerve. The optic nerve consists of about 1.2 million axons. That's per eye, and it's in several parts. You have the intraocular part, which is the optic nerve head, the one, it's the part that you see when you do a fundoscopy in the in your patient. It has an orbital part, basically the part that's inside the muscle cone from the back of the eye and going out into the optic canal. And inside the optic canal, you have the intracanalicular area, which is about 4 to 9 millimeters long, and the intracranial, which is outside of the eyeball, outside of the canal, and going into the chiasm. The chiasm is where the optic nerve merges with the other optic nerve. So this is the front part of the eye. This is when you see in your fundoscopy. So you see this. This is the intraorbital part, the intraocular part, and this part is your the one inside. This part is the one inside the canal, and this part is the one inside um, um, your muscle cone. Now, the one inside the muscle cone is not a very very straight nerve because it's supposed to be able to move when your eyeball moves. Okay, so it can get hit in any of that area. If you have a um, fracture, then you can have a problem hitting the optic nerve there. Or if there's an intracranial problem, a tumor or an aneurysm, then you can have problems over there. The last part is the chiasm. The chiasm is basically this part. It's where your optic nerve met the other optic nerve and it exchanged its nasal component and branched out to go to the other parts to the upper parts of the brain. Its fibers are 80% visual, meaning um, your optic nerve is not just about seeing, it also controls your pupils. So 20% of the optic nerve is for your pupillary fibers, and 80% is from the visual fibers, and they go to the lateral geniculate body. And then it connects with the neurons going all the way to the visual center in your occipital lobe. Pupillary fibers bypass the geniculate body and it goes to the pretectal area. So if you're asked, are all the fibers in your optic nerve going to the lateral geniculate body? The answer is no, it's not, because the pupillary fibers, 20% of the fibers in your optic nerve actually goes to the pretectal area and it does not go to the geniculate body. Okay, optic nerve. The head of the optic nerve is actually supported by what we call um, lamina cribrosa. These are areas that are supporting the optic nerve. If you start seeing the lamina cribrosa, if you start seeing this area, that means most of the optic nerves in this area have already died off. Okay, again, I need to remind you that it's part of the central nervous system. It does not regenerate. If this dies, that's it. You're going to be blind unless science comes up with a different option for you. It's not going to come back. The blood supply is from retinal arterioles from your optic disc, supplying your optic disc, and in front of the lamina cribrosa is the peripapillary choroidal vessels. Inside the laminar cribrosa, you have the short posterior ciliary arteries, and behind it, you have the central retinal arteries. So your optic nerve is actually supplied by several different blood vessels. The rest of your optic nerve have PL-VAD vessels from the ophthalmic artery or the internal carotid artery. So it's very, very well supplied with blood. Okay, so again, just showing to you the back part how the optic nerve is actually supplied, it's practically surrounded by a lot of blood vessels. So thank you. And if you have any questions, don't hesitate to ask or input in the comments below. Thank you.